Good afternoon. It's a pleasure to be with you today. I was excited when Dr. Renica extended me the invitation to speak to this group again. I was here a couple of years ago during the master class meeting, which was outstanding, and thoroughly enjoyed my stay in Cape Town. Today, I'd like to share with you some thoughts about airway considerations in orthognathic surgery treatment planning, enhancing or mitigating the effects of mandibular movements. Historically, the priorities of treatment planning were to establish numerical norms, move skeletal structures to approximate those numbers, hope that it was stable and it looked good. There was really no consideration regarding the airway. That's really changed, however. Treatment planning now, the face is first. We're placing incisors in the smile line in the most aesthetic position, and we're trying to make sure that the airway is indeed a priority. Sleep disordered breathing is fairly common. 9 to 24% of men are affected with this phenomenon, not 4 to 9% of women. And a staggering number of these individuals are actually undiagnosed. These patients present oftentimes with a fairly consistent stigmata of symptoms and appearances. There's bimaxillary retrusion. Oftentimes there's a lower overall facial height. The tongue is oftentimes very large. The palate is very long. There's constriction oftentimes in the nasopharynx. There's a very low position of the hyoid bone, and oftentimes the position of the head is up just to help dilate the airway. The things that we need to consider and that we always consider with our treatment planning are the skeletal and soft tissue anatomic considerations that go into an aesthetic outcome. We want to ensure that our maxillary mandibular positions are good. We want the angle of convexity or facial contour angle to be consistently within the norms. We'd like to have mandibular plane angles taken into consideration, because oftentimes individuals with steep plane angles will have airways that are even more constricted than those which are flatter. The occlusal plane comes into play, and oftentimes we'll utilize that to help drive our overall treatment plan to get the aesthetics, get the appropriate angle contour, and address the possible airway changes associated with the deformity. The hyoid position is oftentimes very low in most patients with high angles, and the pharyngeal airway space is oftentimes very narrow. Historically, lateral cephalometric x-rays were the most widely reported utilization for evaluation of the airway dimensions. However, cone beam CT scans are the new standard, and occasionally we'll use intraoperative fiber optic pharyngoscopy to get a dynamic view of what the pharynx does when patients are sleeping or sedated. The beauty of the cone beam CT scans, we're able to look at not only dimensional analysis, but also volumetric analysis as well. And these are some of the old standards that were utilized relative to the norms of soft tissue dimension, tongue-based dimensions, and what you will typically see in a retrognathic or prognathic patient. What was the significance of that? Well, there were some correlations that were drawn that less than 11 millimeters of PAS and a mandibular hyoid distance which was greater than 15.4 millimeters were oftentimes associated with obstructive sleep apnea. Patients with posterior airway space or pharyngeal airway space of less than 5 millimeters and the hyoid that was exceeded 24 millimeters typically had really significantly demonstrably worse respiratory disturbances. And in this particular patient, we've got about a 5 millimeter AP discrepancy and about a 30 millimeter hyoid position. Axial and Finn in their publication said that there really is no one skeletal or soft tissue parameter, and that would probably be correct. But when you look at the cumulative analysis of patients with narrow posterior airway spaces, great distances to the hyoid, high mandibular plane angles, those sorts of things, we oftentimes have a pretty strong correlation. You can see now with cone beam CT scan, we were able to evaluate the airway, see where our minimal cross-sectional area is, whereas with the plane films, we could only get an estimation of what our airway dimensions were and not necessarily how they related from a volumetric standpoint. Early on, 2001, 20 years ago, Mara Wolford group looked at pharyngeal airway space changes after counterclockwise rotations. And essentially, what we all know is that the geniotubercles tend to move a greater distance than the teeth do with a counterclockwise rotation. And this maximizes the movement of the hyoid bone, base of the tongue, and the associated supportive soft tissue structures. Taking on that, we published a paper in 2015 in the Journal of Orthodontics and Dental-Facial Orthopedics, where we took a group of fairly evenly split class 2s and class 3s and looked at what their airways look like. Our surgical movements obviously were fairly varied because they were treatment planned to the individual needs of the patients. But they were all 2-jaw procedures, feeling that both jaws allowed for a more precise occlusion, especially transverse occlusal changes, greater control over facial balance, and then, of course, our ability to address the airway and potentially mitigate the effects of class 3 movements and obviously enhance the effects of the airway with class 2 movements. Our initial evaluation of these patients were done by occlusal classification, but because both patient groups had counterclockwise rotational movements, we ended up pooling the entire sample and looked at the airways accordingly. And what we found was that there was significant airway volume changes that were associated with the movements of certain cephalometric landmarks. And those were the posterior nasal spine and the mid portion of the symphysis called D point. We have D point moved horizontally, AP in an anterior direction and vertically. We got great increases in airway changes. And conversely, if it went backwards and down, we got this almost proportional amount of airway change. Posterior nasal spine had similar predictive movements as well, and we'll talk about that. But in this pooled sample, when we looked at the total airway for every millimeter of AP movement of D point, we saw a 4% total airway increase or decrease that was changed. This obviously makes sense because we're moving these structures of the oropharynx, and those all directly or indirectly attached to the mandible, and therefore the additional skeletal dimensional change impacted the soft tissue effects at the airway level. Posterior nasal spine movements, we saw constriction because in essence the airway was getting shorter, but getting a short airway is actually a good thing because it decreases resistance as well. But ideally, if you can shorten the airway and increase its overall AP dimension, you're going to get even more improvement in the airway. We saw that as one might imagine, if the posterior nasal spine moved superiorly, there was an increase in the total airway, but the tube got longer, and that was at the expense of the nasopharyngeal airway, and oftentimes it got narrower, so that's not necessarily a good thing. We did see that mandibular autorotation after posterior impaction was not as predictable for us as a mandibular advancement for the correction of the skeletal class 2. So simply impacting a maxilla and getting a small amount of counterclockwise rotation via autorotation was not nearly as impactful as actually moving the mandible forward and upwards with a sagittal split osteotomy. As we touched upon, downward move of the posterior nasal spine decreases total airway volume, increases the pharyngeal volume, or increases the nasopharyngeal volume because the tube gets a little bit shorter. And with Poiseuille's law, that length inversely is related to flow and resistance. So moving it down was good, moving it down and forward was even better. As far as oropharyngeal changes we're concerned, 1 millimeter of AP movement of the mandible at D point, we saw a 4% increase or decrease in the oropharynx, and 1 millimeter of vertical movement of D point and posterior nasal spine saw 4% increase. So a 5 millimeter posterior maxillary downgraft, a 10 millimeter mandibular advancement with 5 millimeters of upward D point movement, we would see fairly consistency, about a 50% increase in volume, and also changes in minimal cross-sectional area. Well, with skeleton in class 2s and class 3, it was virtually the same. We saw that vertical movement of D points significantly affected oropharyngeal airway and total airway volume in class 3s. We didn't see it as much in class 2s. However, there were positive findings given that vertical repositioning of the mandible should be more prevalent in class 2s because of auto-rotation, but you can in a class 3 get auto-rotation upward and backward with counterclockwise rotation, so we tended to get improvements there. But upward movement of D point was seen in class 2 division 1s. Downward movements were tended to be seen more often in class 2 division 2s because these patients tended to have more clockwise rotations. These patients tended to have more counterclockwise rotations, or at least a greater percentage of clockwise rotations. So in conclusion, we found that you could really look at posterior nasal spine and you could look at D point and you could engineer into your treatment planning favorable movements for the airway. And of almost every single one of those were counterclockwise movements, and that could be done in both classes. And you can do counterclockwise rotational advancements if the face will tolerate it to help protect the airway. We'll show you some examples of that. So this is a patient with a mild form of hemifacial microsomia, tremendous amount of yaw, chose to do a joint replacement because of volume size, medialization of the condyle, and just geometrically, it made a lot more sense. When you looked at this this patient, we saw that there were axial changes in the shape. Not only the airway moved superiorly, but it changed its shape dramatically, and we got increases in volume. And you can see what happens between our pre and post-op, because now we've got this ramus equal more in vertical position to the contralateral, more normal side, and we saw a change in airway becoming a little bit more ovoid and with a much greater AP dimension. We saw with our minimal cross-sectional area changes that it almost invariably moves superiorly with the counterclockwise move, which you would expect, and that there were area changes and they increased the posterior nasal spine and D point were well controlled and moving in favorable dimensions. And again, that there was a lateral, from a lateral ovoid type of shape to a more round type of shape, which again diminished the airway resistance associated with it. Well, with skeletal class 3 counterclockwise setbacks, we looked at what happens with airway there. And you can see with this particular patient, if we can move the incisors back, but the chin forwards with a counterclockwise rotation, we'll oftentimes see that the hyoid will change positions, the airway will improve. And when we looked at our analysis, oftentimes that did change. And so you look at this patient post-operatively, and what you'll find is we had a multitude of favorable movements. You know, we had A point moving vertical, which is a good thing because we had auto-rotation. We had D point had a horizontal change, which was 1.8 millimeters back, which was not necessarily a good thing, but it was countermanded by a D point moving superiorly, almost the same amount. So these really kind of balanced themselves out, and it was a sum zero for the most part. But we got upward rotation of the with auto rotation because of this A point movement, which was a good thing. And then there was movement also of the PNS, posterior nasal spine, inferiorly, which was also a good thing. And you can see our post-operative results. We had a fairly significant change in the minimal cross-sectional area as well. In our post-op minimal cross-sectional area, we saw that, again, that there were changes in its vertical dimension, increase in airway changes, and airway shape. So our treatment planning considerations in this regard were, it was best to try to get a D point forward and upward. We wanted to avoid posterior linear movements, which it is very, very rare for me to have any linear movements at all with the mandible. I invariably will have some degree of counterclockwise rotational advancement, especially with the high angle class 3s. And that you could get very positive changes, not only in the class 2s, but also in the class 3s, utilizing these rotational movements. And Dr. Rennick has done a beautiful job over the years of explaining these the principles of rotational movements. These were originally the primary rotation movement, rotational points, but they've since been expanded to look at a number of different positions that you can get rotations. You can rotate and move posterior nasal spine up or down, which is going to impact the chin, but not impact anterior nasal spine. It does unfortunately impact incisor position, so that's not often used. You can see that you can take the incisor tips forward, which I tend to treatment plan everything around the incisor position. So I may have some changes up here at anterior nasal spine, posterior nasal spine, and obviously at the chin. And you can see green being clockwise movements and red being counterclockwise movements, with the red all being very favorable movements and green being more unfavorable as it relates to the airway. You can have movements at Pogonion. That doesn't happen very often. Oftentimes that's going to be a class 3 where you're trying to get a lot of mid-face projection, where you're going to jump the maxilla, couple the occlusion, then rotate around Pogonion to get more movement in the upper aspects of the rotation triangle. With the incisor tip rotation points, subnasally tends to move back while Pogonion moves forward if you're doing a counterclockwise, which is the majority of what we typically will see. And then these alternative rotation points are really most helpful when you're trying to get large movements of Pogonion, and they tend to, most of my movements tend to be somewhere in the mid portion if we're doing impactions. The less you're moving the anterior aspect, the more that rotation point moves forward, and may actually just be a coupling of rotation points between the incisors and somewhere along the buttress. This is a pretty common rotation points, especially with VME patients, high angle VME, because you're going to move the maxilla up typically, or in a short vertical dimension class 2, you may bring it down. But you can see the impact of chin position with these various rotation points, with posterior nasal spine going up, anterior nasal spine going down, and Pogonion going backwards. And of course, you reverse that with your class 2s. But you take an example, this is a particular patient it's got a moderately high degree mandibular plane angle. Maxilla clearly needs to come forward, the mandible needs to go back. The idea, though, is to rotate the chin back. If you want to rotate the chin back purely, you'll do a clockwise rotation. If you want to move the chin forward, you'll do a counterclockwise rotation. If you want to move the dentition back, you'll use a counterclockwise. If you want to move the dentition forward, you use a clockwise. So these movements can be used to enhance the corrective effect at the midface or mitigate the effects on the lower face and the mandible specifically, but they also can be used to mitigate the impact at the airway, because again, we're talking about what happens at D point here and posterior nasal spine back here. And so just diagrammatically, you can see a patient that's a skeletal class 3, kind of a moderately high mandibular plane angle. You can see that we're rotating the teeth backwards, pushing the chin forward, bringing the hyoid forward, and then just dropping that occlusion into position with the incisors coming somewhat forward, balancing the face, getting very minimal change at the dental level, but actually seeing that the mandible comes forward to again support the airway. So really kind of a good rotational movements. And there's just another example of a class 2 where we're going to utilize more of a buttress rotational movement. And you can see again that the incisors are going to come upwards, but not advance as much as the chin does, with the posterior maxilla dropping into position, rotating somewhat around the mid portion of the buttress. So these rotation points can be selected based upon what your overall goal is going to be. And you look at this young lady, she's got an extremely high mandibular plane angle, very straight chin, very high occlusal plane angle as well. Airways very, very small, and a very convex facial profile. So we treatment planned her for her maxilla to come forward about 4 millimeters. We were going to do a 2 millimeter impaction, so we're getting about 6 millimeters of change here. We got a 4 millimeter posterior downgraft, so we're up to 10 millimeters of approximate change. And by the time we did our counterclockwise leveraging, we were able to get the mandible forward about 14 millimeters, with 10 of it coming with this 4 millimeters, 2 millimeters, and 4 more millimeters of skeletal movement, and about 4 millimeters of genioplasty or genioglossal advancement, changing our angle of convexity from 21 down to 10 millimeters. And you can see doing a conventional model surgery, the magnitude of move that you get with these types of movements. Obviously, you need to do the mandible first, otherwise your surgical splint will be extremely thin, and you'll already be getting translation of the condyles, which can affect your condylar position with your rigid fixation. So mandibular surgery first in this scenario is always advised. And you can see with that, you're basically just creating a small posterior open bite with a very large mandibular advancement, and the maxilla then just settles into position quite nicely. And you can see what that looks like. We've got a tremendous change in our airway. So you've got a facial profile that's been nicely balanced, and I think a reasonable result. Another example, segmental lefort with advancement, counterclockwise rotation, genioglossal advancement as well. And you can see her overall aesthetic result. What you don't notice, and it looks like, well, golly, we didn't do much good on our two-dimensional films, but when you start looking at what happens with in your cone beam CT scan, significantly better airway changes than what you would see on a conventional lateral cephalometric x-ray. This is kind of a dilemma patient. This is a patient that clearly needs a probably a two-jaw procedure, but there's some that might just say, well, we'll just treat it as a single jaw position, a single jaw type of case. And if you choose to do that, you can do a maxillary osteotomy with posterior impaction, and by moving the posterior maxilla up, you'll get auto rotation. You might have to advance the maxilla because she's going to auto rotate into a class 3. You can do a maxillary osteotomy with posterior impaction, and then do a genioplasty to improve her angle of convexity, which is fairly high. You can do a two-jaw with a chin, or you can do a two-jaw with open bite closure in the mandible. It's interesting to see what each one of those does. If you look at the angle of convexity, here we have a maxillary osteotomy with posterior impaction, and with nothing done on the mandible, and our angle of convexity changes 1 degree. You look at a two-jaw procedure with a posterior impaction of 4 millimeters, which is a lot, steepens the occlusal plane considerably. Where our occlusal plane is now 18, which is, in my view, unacceptably high. But this is a doable treatment plan. The mandible then has to be set back 3 millimeters. If we just look at all of the discussion that we had previously, these are all very bad movements for the airway, because posterior nasal spine goes up, the mandible goes back. It's just not really particularly sound treatment planning in my view. Now, you can do the same exact treatment plan, but you can mitigate your angle of convexity with a genioplasty by sliding it forward, 4 millimeters. If you make your cut high enough, you'll pick up the genioglossal muscles, and that certainly is an improvement, because now you have the angle of convexity at 13. However, I chose in this particular patient to close the open bite in the mandible, and I basically moved the maxillary ones about 1 millimeter forward, because with the amount of auto rotation, I wanted to try to get to an angle of convexity of about 10. And that's basically what we were able to do. But what's really impressive when you see the treatment plan is everything that we did was very favorable. We didn't mess around with posterior nasal spine. So we didn't change the oropharyngeal airway volume. So most of our airway changes were fairly low. We ended up moving D point up, and we moved it forward. We moved them up and forward quite a bit. And you can see that she's very, very stable, got a beautiful occlusal result and a facial result compared to what we had. And airway-wise, things had an absolute dramatic improvement with the tonsils moving upwards and laterally, the nasal pharynx opening up, and the oropharynx opening up quite dramatically on all of her postoperative cone beam CT scans. And this is just another example of a patient where we did total joint replacements on one of our Native American patients. And you can see pre and post-op, fairly substantial changes, did a genioglossal advancement as well. And you can see here fairly substantial changes, especially at the nasopharyngeal area, but also down at the level of the vallecula, and her minimal cross-sectional area improved dramatically. And again, just substantial results, changes in the results of her airway volume. Another classic example of a patient with vertical maxillary excess, maxillomandibular retrusion. We were able to treatment plan her for about a 10 millimeter AP change, even though she had virtually no sagittal discrepancy in her dentition. We were able to move our maxilla forward 3, up 3, so we got about 6 millimeters of autorotational change there. And then we got a bit of mandibular advancement with our posterior downgraft, which facilitated the mandible now coming forward a total of roughly 10 millimeters. And you can see we balanced the profile nicely, improved her overall facial dimensions, and improved her airway quite substantially. And you can see on her postoperative cone beam CT scans how impressive these changes can be. So class 3 considerations obviously are going to be a bit different because our airway considerations are a little bit greater. We know everything going forward is going to be helpful, but we've got to be worried about the maxilla and maxillomandibular complex if the mandible moves backwards. And there's been multiple studies that show that there's a decrease in AP airway dimensions at the level of the soft palate, the tongue, and the vallecula if there's just pure linear movements with class 3s. And so you're probably wise to do 2 jaws, because that's also been shown to mitigate some of the impacts on the airway in the class 3 patients, because oftentimes you're splitting the difference between the maxilla and the mandible. But going back to just isolated mandibular setbacks, you can get substantial changes in the airway, with them being upwards of 40 to 55% of the magnitude of the dental setback. So you really don't want to do that. And that's basically what we found. We found that we could mitigate our class 3 airway effects by using 2-jaw procedures and doing those with some degree of counterclockwise rotation. So with the high angle class 3 treatment planning, most of the time they're going to rotate further down this anterior limb of the rotation triangle, oftentimes rotating clear down either around the incisors, or more often rotating down around B point. If you rotate around B point, then the incisors move back significantly more than the chin, and because D point moves up and forward, you have less impact on the airway. So the other thing is that we want to try to, with these counterclockwise class 3, is if we move the posterior nasal spine downwards, we get that increase in volume by decreasing the oropharyngeal, but we enhance the nasopharyngeal volume. So lots of things at play here, but the important thing is that if you can control posterior nasal spine, control D point in your treatment planning, you're going to find that you can mitigate the effects on the airway. You're going to shorten the airway, which means less resistance, and you'll oftentimes minimize the amount of constriction that you actually have on the airway. And here's a young man, class 3. We treated him years ago, kind of in an analog phase during our analog treatment planning days. And you can see all the parameters of a high mandibular plane angle, high occlusal plane angle. Great looking airway, kind of got that class 3 look to him with mid-face deficiency. So I basically advanced his maxilla and did a counterclockwise rotation of the mandible. And you can see this as I toggle back and forth, that the incisors came back, the chin came forward, and then they were able to set the mandible down into an appropriate position. And you look at him, and even though he had a pretty well-shaped chin, that little bit of extra helped support his airway, and we had very minimal change back in the days before cone beam CT scanning of his overall airway dimensions. But you can see we got a good aesthetic result. Here's just an example of a young man that I treated here in the last 2 or 3 years, where, again, he's got a high occlusal plane. So really what I want to do is just kind of rotate the teeth back, but I really would like to keep the chin dimension pretty good. I mean, he's really got a pretty decent profile. He looks a little bit mid-face deficient. And so in his particular case, what we did is we did a virtual surgical plan, and you can see his preoperative position. You can see his postoperative position. You can see counterclockwise rotated because we've got inferior aspect of our medial dental bearing segment being below the mandibular plane. This is obviously diagrammatic. We tend to split these in a way that we don't have that excess bone hanging down. But more importantly, interestingly, when you superimpose him, you can see that with this is his final position, that his chin has not moved at all, but the dentition has moved backwards, and we've got a little bit of changes in the proximal segments. But all in all, we're able to do a counterclockwise rotational advancement. You can see the amount of counterclockwise movement based upon our purple versus pink. But what was impressive was the amount of his regional airway. It changed absolutely dramatically. So we were able to get effect of nice occlusal change without really changing his physical appearance. Actually, we got a good mid-face projection, but his airway actually improved somewhat. And just another example of the same type of surgical movements. Where we advance the midface, we rotate the teeth backwards to project the chin a bit forward. You can see on 2 dimensions, we get good projection and really pretty impressive changes on our cone beam CT scan, and changes again in the shape of the airway. You can see I really like to advance maxillas. Most patients get some degree of maxillary advancement in my treatment planning because I think it helps to fill out the buccal corridors. This is especially important on patients who choose to do class 2 or even class 3 extraction patterns on that. You'll want to fill that out to get to your aesthetic smile line. But again, you can treatment plan these patients very, very nicely to improve their airway, or at least mitigate their impact of that mandibular movement on the class 3s. And just another example. And a patient here, very similar situation. You can see he's got a very flat occlusal plane. I want to rotate these teeth upwards and backwards. I'll advance the maxilla a little bit because we know that'll help posterior nasal spine dimensions and upper airway positions and dimensions. So we'll rotate the teeth back a little bit. That'll kick the chin forward. That'll bring hyoid forward. That should open up the airway. And again, you can see this is a gentleman that had an angle of convexity of about 5. He's now at about 12. So we've actually made him a bit more convex, but the fact that his teeth move backwards and chin move forward really were quite helpful. And you can see what he looks like. And again, the changes on 2-dimension and 3-dimension. So in summary, our surgical design can really enhance or mitigate the airway impact. You can see that forward movements are always good. Backward movements are mostly back, unless you can mitigate those movements with some vertical changes in the incisors or D-point. You really do want to avoid isolated mandibular setbacks. You want to try the best you can to get D-point to move upward and forward, and you want posterior nasal spine to move forward and downward. And actually, counterclockwise rotations can really help to mitigate a lot of deleterious effects of the airway, especially in class 3s, but we know that always help patients with the class 2 situation. And with that, I'll thank you for your attention and the opportunity to spend a few minutes with you today.